we're super excited to welcome Dr. Erwin Mangubat for today's webinar. Thank you so much for taking the time to speak with us.
Thank you. Thanks for having me, Sai.
All right, so we're going to go ahead and get to the first question for today. Could you start by giving us an overview of your role as a neurosurgeon at Prisma Health and an assistant professor at USC?
Yeah, so as a neurosurgeon, I mean, it's pretty wide breadth of coverage. I mean, we're at a level one trauma center, comprehensive spine center, and I do cover a good bit of things. So as far as like the head trauma, we cover stroke, spine injuries, that sort of thing, and that's not, obviously not including all the elective things that we do, elective spine aneurysms and so forth. Um, uh, Also, there's a lot of facets of neurosurgery. You can talk. It's not just like cranial and spine anymore. There's as far as cranial. There's trauma. There's like oncology, so like cancer. Even like you can break that down even to skull base, so like the base of the skull. Um, type of tumors that can take lots of folks get specialized training for that. There's uh, 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 neurovascular, both open and endovascular as well. So that's aneurysms and strokes. And then as far as more so with cranial, there's like the functional part, which I do as well, is for like deep brain stimulation, for treatment of like Parkinson's and tremors and dystonia and that sort of thing, epilepsy, as well. And for spine, again, we do share a lot of the, we kind of were talking about it earlier, offline, but we do share a lot of similarities to orthopedics in terms of spine and spine fusions and corrections and that sort of thing. And then yeah, and then we do have I don't personally do, but there's that's we have pediatrics covered by a few other two of our other neurosurgeons as well. So the breadth of neurosurgery is pretty wide, and it really takes a big team to cover all the facets.
Yeah, absolutely. And I was like also wondering while you were talking about the different fellowships and specialty or specializations that you can do within neurosurgery. Could you shed some light on those specific
Yeah,
ones or all of
yeah,
the ones
yeah.
that they have?
Yeah, for the most part, if you're looking to do kind of general neurosurgery like trauma and basic spine and that sort of thing, you don't most I think most neurosurgical residency provide that training. I think it's really right at this point only about half of graduates go into specialized fellowships, and most still go into general neurosurgery, which is fine and great. But yeah, there are different types. The most common ones are like endovascular, and cerebrovascular. There's an oncology as well, but really when you do oncology, you're kind of setting yourself up or planning to do more be in the academic field. Um, Spine is always a big one, and obviously pediatrics, endovascular. The endovascular is one that you have to have some sort of fellowship to gain privileges to do that, in an outside facility, on your own in a facility. And there's epilepsy, and functional neurosurgery. One that's not as popular, I think, but is still pretty fascinating is peripheral nerve, and that's one that's kind of shared with still plastics and some orthopedics and that sort of thing as well. So
Yeah, and I remember we had a case when there was a patient with a brain tumor that you took out with the gamma knife technique, and then it I think it came back. But I was wondering, so your fellowship isn't within oncology, so where's the line drawn between being able to do oncology like procedures and not?
so gamma knife. in radiation oncology procedures, you don't, that's not one that's you necessarily need a fellowship. Um, Really, that's a great question. I mean, and that's something that um, again, a lot of neurosurgeons well, all neurosurgeons have to develop some sort of sense of self and be honest with themselves and what they're comfortable with doing. Um, even though they may have privileges to do like a complex spine fusion, but if you're honest with yourself and you don't, if this is going to be your first one or you don't know how or whatever, you just don't feel comfortable, you have to be honest that you say, hey, mate, I got to pass this to somebody else. The only thing that truthfully that you really do need privileges, specific training, is again is endovascular. And that is something that you do have to submit to institutions, case log and letters and that sort of thing, that you have privileges to do that. Um, Other things are also like skull base as well. I think to some extent. I didn't do a specific skull base fellowship, but I still do like pituitary tumors and take down the orbit to take down pretty complex tumors. But I had that experience in residency, and one of my colleagues, Dr. Moftakar, he helps me. We help each other quite a bit. So again, it's all about being honest with yourself for the most part and what you feel like you can accomplish. Um, which is better, which is good and bad. I mean, I've seen, quite honestly, I mean, I've met folks that and seen work that that maybe these probably would have been better off in someone else's hands. I mean, you see that often, um but yeah, I mean, to that's a great question you asked, but to answer your question, outside of endovascular and maybe some skull-based stuff like using endoscopes and that sort of thing, there really doesn't you don't really need special fellowship um, to do a certain most things.
Yeah, that makes a lot of sense. I remember shadowing orthopedic surgery and also while working in interventional radiology. Certain physicians feel more comfortable or feel better at doing certain procedures or certain parts of whatever their specialty is, compared to other doctors. And honestly, like it never really clicked into my mind until you were just talking about that. So I think that's really cool because some people can do certain procedures more efficiently than others and
Hmm.
vice versa. So
Yeah.
that's really cool. Uh, so moving on to the next question, it's a little bit about your journey. Can you walk us through your path from the University of Illinois uh, to MD, MPH, and then neurosurgery residency, and then your fellowship?
Yeah, sure. So I think pretty early on I wanted to do medicine. Kind of similar to you. Come from family that are not necessarily physicians. My mom is a nurse and my stepdad's a physician, but he really didn't come into the picture until like after college. But regardless, but yeah, no, yeah, I did my undergrad University of Illinois. I did a biochem biochem was my major, pre-med, that sort of thing. Got into some research. Is more like bioinformatics, so it was mostly like computers and stuff like that. And ended up going to University of Illinois, Chicago. And MD. I got an MPH, and actually I did my MPH between my third and fourth year, and a lot of that was to just kind of boost my CV. Truthfully, I mean, I think I got a lot out of it, and I definitely would have done it again. Um, a lot of it was, I think I got from it was more sort of the bioinformatic part, and learning how to read papers and that sort of thing was very helpful. Um, and then during that year, I did a lot of kind of basic science research. With my mentor at the time was Dr. Ben Royberg. So we were doing research with in essentially a stroke model and delivering stem cells to kind of the stroke part of the brain in this monkey model. So I did that for the year, which was pretty cool. And then after that I got into residency at Rush, and spent the rest of my time there. And then I did two fellowships. I did one at uh, functional and epilepsy in Seattle for a year. And then I did a cerebrovascular endovascular fellowship at Rush again when I coming back. And then ended up here in South Carolina once my he was my attending at the time, Rohan Moftakar. He came here to South Carolina. I ended up joining him. So
And I know you said that you got the master's in public health as like boosting your CV. How have you seen that affect the way you approach medicine or the way you think about medicine as a neurosurgeon?
yeah, I mean, again, I think a lot of it was helpful to help read papers, but I think there's a lot said to what we do in caring about public health and that sort of thing. It helped me kind of it helps me remember sort of the bigger picture of why we do things. And just taking care of each other, taking care of society as a whole rather than just, each individual. I think that was really, really kind of helped me keep that in perspective. Um, uh, you know, yeah, again, I thought it was a worthwhile thing. Did I absolutely have to get it? No, but does everyone need to get it? No, absolutely not. But at least for me, it helped me learn about other things outside of patient care, just kind of community health, and then also what helped was learning a little bit more about health administration and that sort of thing. So yeah.
Yeah, I know, especially nowadays when gap years are getting a lot more popular, a lot of students pursue a master's in public health or additional schooling, a master's of some sort. And I've always wondered how that has affected their approach to medicine, just from more of a overall approach like you were talking about.
Mhm.
And that's, I don't know if I'm considering a gap year just yet, but if I were to, that I feel like that would be something I would be interested in.
Yeah, if I could go back, I mean, I would strongly consider like a master in science as well. I mean, I think again, I think just being able to interpret papers and write papers and that sort of thing, that's something I had to kind of figure out later in my career, like not until kind of residency that I had to figure out if you kind of know how to do that from the get-go. Um, it's a strong that would be very strong thing to have because I know we're going to go into you can ask me about residency and stuff like that, but when you get into residency, most programs they're going to have you want publications from a resident, at least one or two publications a year. So being able to have that skill set up front will be helpful. Obviously, there's I'm not I'm not saying it's a bad thing, truthfully, but with AI and that sort of thing, Chat GPT and cloud and that sort of thing, I think it's I think in the end it's very helpful. I mean, to help kind of structure things. It's not to necessarily replace your thoughts and what you're doing, but it does help kind of structure things to make things more that way you can get things done more efficient, write things more efficiently. At least that's the way I've been using it recently. So and yeah, but so again, I think gap years are great. If I had to go back, I'd probably strongly consider that. Yeah.
And so this is kind of like two questions in one. First question is what originally drew you to neurosurgery, and how early did you start with research in undergrad and also in medical school?
Yeah. So, I think what's very helpful before or early on when you get into medical school is just to kind of figure out. I think I told you before is just figure out whether or not you want to be on the you know in the OR or outside of the OR really, because the tracks are pretty different. So if you want to do like family medicine, if you want to do primary care, that's awesome. But try it's important to learn what goes on in the OR, but um focus on that when you're training and so forth. But like surgery is a little bit different. I mean, it's there's a completely different. You do have to have truthfully you have to have a certain skill set. You have to be pretty good with your hands, and you have to be good with time management, and so forth. So it's important to kind of figure that early on. Um, but for me, I knew I really wanted to get into surgery right away. My mom worked at a cancer treatment center. I thought that's where what I was going to end up doing was cancer, a surgical oncology. But it was really early on in with medical school with neuroanatomy and neurophysiology. I really gravitated towards that. Honestly, I was okay in gross anatomy. I found it kind of gross. It was just I didn't really enjoy working on cadavers and that sort of thing, and I still don't. But the really what I gravitated to was more the neuro stuff, the spine, the brain, and that sort of thing. And it just made more sense to me. And then that just kind of translated to just doing research pretty early on. I think I started doing research after my first year, and that's you know there's at least where I trained, or at least where and when I trained, you still had sort of a summer between your first and second year. So during that period, I started doing research with with a surgeon, Ben Royberg, and started just getting in and helping write papers and that sort of thing early on. And then honestly, I just stuck with it. I enjoyed it. Truthfully, my the I had decent grades, but at least for what the other neurosurgeons there, the attendings, they thought it'd be better to kind of help take some time to kind of boost my CV and that sort of thing. That's where that MPH came from, and also doing more research. I still think that neurosurgery is probably still pretty competitive. I haven't been in the game uh, haven't applied for neurosurgery. It's been I'm 10 years out into training now, and I was seven, so it's almost Jesus, it's almost 20 years since was applying for a neurosurgery residency. So things have changed quite a bit. But I think if anything, the biggest thing to demonstrate how dedicated and how much you enjoy neurosurgery is being involved in research. I think that's a big thing, and kind of doing what you're doing too, Sai, coming and shadowing and that sort of thing. So, honestly, it's grades, um, uh, demonstrating uh, um, interest in it, and I think a big way to do that is research. And then, letters of recommendations are always going to be very helpful. So, yeah.
And I know there's a large dilemma for students who are interested in surgical specialties, but also not very interested in research. What advice could you give to students in that predicament?
I mean, I think so they want to do surgery but not research.
Hmm.
Yeah. I mean, that that is a predicament, but honestly, I think it's that the way I would think about it is sort of research is the way you're paying your dues to get into it. And a lot of what we do in getting into things is, like anything else, is like networking. And so being able to publish, you don't have to like publish papers that are going to be printed in journals and that sort of thing. They can be like abstracts or just poster presentations that are going to be potentially presented at a meeting, and there's like tons of those, right? And there's multiple meetings, different meetings, all the time. So being able to do that kind of stuff, I think it would be very, very helpful. Again, it doesn't have to be something that's like published in a very powerful journal or anything like that. But the way that, again, the way I would think about it is just the way that you're kind of just paying your dues and demonstrating to the folks that you're trying to impress, you're trying to convince to let them in your residency that, hey, I have a lot of interest in this. You know what I mean? And then, honestly, like I haven't, I feel bad because I do come from an academic, I do a lot of academic things as far as like, do a lot of epilepsy and, functional neurosurgery. And, I do a lot of cool endovascular stuff, but I haven't published anything like personally outside of just putting my name on being a part of some papers in a few years. So, and but yeah, I just unfortunately that's just the kind of what it is. And I don't have residents, I don't have fellows. I do have some medical students that are kind of working on things with me, but again, I haven't published anything. In a while. So it's just kind of what it is. Like I said, just it's paying your dues and showing it the way to show interest.
Do you often see a lot of surgeons who are really interested in research like yourself stop doing research once they become attendings, or is it just because their schedule is so packed, it's hard to make time
Oh,
for research?
most neurosurgeons, I would imagine don't do any research. Yeah. I mean, and that's not a problem. It's not a bad thing either. Most neurosurgery are done by, you know, there's like consider, I guess, academic neurosurgery and then general neurosurgery. Most neurosurgery is done by community neurosurgeons, and they generally do a very good job. So, and there's nothing wrong with that, and just kind of focusing on, your day to day, doing a good job, taking good care of patients. And then, there are those academic folks that want to, drive the field and that sort of thing. But at the same time, usually those folks aren't the ones that are, doing high volume surgery. You know what I mean? Just because they're focused on they're on their academic goals. So the good thing with medicine, good thing with neurosurgery. I mean, I think in the end when there's a lot of different roles out there. I mean that you can figure out, and you could probably be pretty happy with if you want to focus on. I hate to say it, but if you want to focus on you know, um, making a good living and being comfortable, that's okay. You can do that. If you want to focus on making a big name for yourself, in the academic realm, that's great too. Um, there and there are some that is kind of in between as well, but again, it's really whatever you want to make of it. And also, truthfully, it's a lot of it is also where you end up too. Where I ended up here. Um, we built a neurosurgical practice. We're still waiting on to develop. We're still hoping the next years we'll have a fellowship and residency where we will be a little bit more academic, where we don't have to focus on generating, RVUs and that sort of thing, and just hopefully focus on contributing to the academic field. Hopefully we can do that, but we just make the best of our situation right now. You know what I mean? So.
No, I totally understand. I think last year I was really considering maybe potentially going MD PhD route, before I really understood what that entails. Like I was very interested in research, but also very interested in the clinical side of medicine. And with MD PhD, you often see yourself doing more research than you are being in clinic, and that's not the approach that I would want. But some people do, and that's a lot of people who do pursue MD PhD, like you're talking about, doing more academic things than seeing patients. But the benefit of going MD and being a surgeon or being a doctor or any of the different specialties that you still have that opportunity to go into research. And I didn't know that before, and I don't know if a lot of students did, but that really made me decide that I wanted to go MD or DO route. So
Mhm.
I completely understand. So moving on to the next question, I know you talked about a few of your mentors. If there are any mentors, feel free to mention them as well. But could you talk about some impactful patient cases you've had in residency, your fellowship, or as an attending?
Yeah. Yeah, sure. I think it's more, honestly, I don't residency and fellowship feel like such a long time ago. I think it's just because of just, the sheer volume of cases and acuity of cases and just kind of the emotional toll, some of the patients take on you here. It's I can probably more comment on obviously the more, since being in practice. I've been here in Columbia for about 10 years now, South Carolina for about 10 years now. So, um, I can't remember necessarily the name or anything like that, but it's always, specifically because, it happens not every time, but here and there. But, what always impacts me is when we go into these fields to help people. But it's always impacts me when, you have to break the news that there's nothing to do, right? I mean, if the head bleed is so big that the patient has truthfully no chance of neurologic recovery, the patient is, cl near is or close to being, brain dead, there's nothing to do. Trying to break that to family is always hard. Um, and you don't always get, you can't always get over that. I mean, or you can't always, that's never, it doesn't ever get easy. Another one is, I think just even more recently, is, you do the best you can. We had a recent, a few months ago, I had a patient that had, um, systemically pretty good controlled, um, ovarian cancer. She had a metastases to the brain, to the cerebellum. We resected it. She had other smaller areas as well, and those were radiated, and they seemed to respond. But she came back maybe a week later, or not a week, 2 or 3 months later, and it's back. It's all in the neuro space, and her whole lumbar sacral area is just essentially caked with tumor. So what we call that is leptomeningeal disease. Um, it's bad. It's just bad. Even though it has good systemic control, the disease has just progressed, and again, it's just hard to kind of break that to patients that who are it's like this patient who's like functionally doing okay. She has all her cognitive function and so forth, but she has a lot of pain in her back and that sort of thing. And to kind of tell her that there isn't anything we can do. We need to, have to focus on like palliative care. That's hard. Um, as surgeons, we want to do the best that we can. But it happens that we get complications. Majority of the time, the complications are things that are out of our control, but they do happen. So obviously those things do happen, but that's kind of just you just have to make sure that you again explain to patients and their families that we're human beings, that we are taking oftentimes high risks here to do something, and a lot of unexpected things can happen. But when they do happen, those unexpected things do happen, it still doesn't feel good, you know what I mean? Um so yeah, I mean, if anything, I think I do have a lot granted, I do have a lot of good wins and, taking care of big aneurysms and taking away people's tremors and helping people not have seizures anymore, doing, good, stroke, meaning, doing something called a thrombectomy where we can pull a clot out of someone's, middle cerebral artery, internal carotid artery, and they wake up and they're moving that side, their contralateral side again. I feel like I have a lot of those stories as well. But, truthfully, what sticks with me most is the ones that I couldn't help or, that what I, potentially made worse. And, it's just kind of what it is. And, those are things that you just have to um, accept and you have to learn from and, just do your best that it doesn't happen again. So, I think if anything, that those are the cases that I remember, and that's where really the ones that I learned most from. That makes sense.
Absolutely. And the emotional toll, I mean, for the past 20 years from originally becoming a first year resident to now being an attending, how have you grown to cope with those emotional tolls and your mental health and keeping work at work and not bringing it home?
Yeah, that's really hard. That's and it doesn't. I'm still learning of how to do that. I mean, um, I think what's helped is just I have a very understanding partner. My wife is very, very understanding. My kids are wonderful. Right now they're 5 and 11. At least, they're wonderful now. So, um, but they're pretty wonderful. So, it helps. That really helps me kind of forget things for a short period of time. But at the same time, as neurosurgeons, as physicians, you're at least for me, I'm always on, meaning, if I have a patient that comes in, whether or not I'm on call or not, and they need something, I'm going to be available for them. And that's just kind of the nature of what we do. I hate to say, I know there's this trend for like a work-life balance, and I think that's important. Um, but it's hard to let go. I mean, again, I have a very understanding wife that knows that the only way for me to that I can take a break is if we like leave the country and be so if we go so generally we take a trip out of the country once a year, that sort of thing, where I can just kind of let go. And again, also it's important to have good surrounding cast at the hospital. So I have great partners that, if something comes in, I'm not there, I can trust that there's one of them's going to take care of them. And then also I have my, although we don't have residents or fellows, I have, nurse practitioners or PAs or advanced practice providers, however you want to put it, that do their best to kind of shield me from things, and understand that I need a break too, because, when you go into medicine, it's a special person. You will, I think most people want to be there, want to care. They care for their patients, and, want to be there for them. So it's hard to 100% let go, and you don't always do, but but you have to do your best. But in the end, it's the relationships that you have at home, and that you choose to have at home, and who you bring on. So, uh, yeah. So it's but it's hard. It's hard. It's still it's hard to separate, but it's important to kind of take that time. So.
And as you just talked about your family and you mentioned in your bio that your family is your greatest passion. So how do you see how does having a family help you be a better neurosurgeon?
Yeah, no, the way that the best test of whether to do surgery or not, either spine or an aneurysm or what have you, is to consider whether or not you would want that surgery for your wife or your kids. So I think that kind of having them in my life really kind of puts that in perspective. And you know what what the toll that I'll take on that, not just that patient, but everyone else in that patient circle. You know, so for me to, to consider doing surgery on somebody, it's not, I don't take it lightly. You know what I mean? So, it's not a, hey, let's try this and see if it'll work. It's like, hey, we'll try this because I'm not 100% sure it'll work because I can't ever say that, but, or I don't think anyone can, but we can try this because I'm optimistic that it can work, and I'm optimistically that it can make your life better, functionally better, take your pain away, again, take your tremor away, reduce your risk of this aneurysm bleeding, that sort of thing, right? Obviously we don't have a crystal ball. We can't 100% tell that, but it's almost like a gut feeling. Hey, gut feeling plus all the some of the evidence-based literature that we have, which isn't always perfect. Um, but it's that plus whatever evidence that we have, and applying, hey, I would want my kid to have this procedure if she had, if my kid had this vascular malformation, I would want it treated this way, right? Um, so yeah, I mean, so that's how that's a huge thing how I kind of approach things these days, having a family.
No, that makes a lot of sense. And especially within the field, how have you seen it grow from when you first became an attending to now, based on the different procedures and the success rate and also research and all that to make it to make the success rates higher for these types of surgeries?
Yeah, the biggest things that I've kind of very fortunate to be involved in sort of the this innovative time of neurosurgery. When I started neurosurgery, things like deep brain stimulation for Parkinson's and tremors, and that was first. It's been FDA approved in, like, 1998. You know what I mean? So uh, to you guys, it might feel like a long time ago, but when I started training, that wasn't, very long ago. You know what I mean? It was still pretty recent. So to see how important that's kind of developed, the new techniques and the new tools, the way that the technology has developed, where we can kind of shape the electric field in the brain to stimulate things that we want to, and stimulate and keep stimulation away from other things. Um, uh, that, using things what we call local field potential, that we can measure kind of the EEG at the level of the nucleus, and kind of titrate the stimulation, that sort of thing, to take away the patient's pathology. um, Using things like lasers, to take care of rather than doing it like doing a big craniotomy to resect the hippocampus and the amygdala for epilepsy. We can either implant a device, almost like a pacemaker in the brain, to um, uh, to essentially abort seizures when they come, or if it's safe to, we can, rather than resect, we can place a laser fiber in that part of the brain, and heat it up, and essentially injure it to the point of destruction without resecting it. So it's been really amazing, and all that, plus, the way that we look at the brain. We don't look at the brain as other, structures, like this is where your speech is, this is where how your hand, this is where your hand moves. It's all connected. We look at different fiber tracks now. So it's and with things coming out with brain computer interface, things like what Tom Oxley's been coming out with the Stentrode for Alzheimer's for ALS, and Elon Musk with everything else with Neuralink. Those things are becoming reality, all within neurosurgery, and those will be things that the rest of us will be able to implant probably in the next 5 years or so, I would imagine. So it's an amazing time to be in neurosurgery, because we're at a point where we're not just um, potentially saving people's lives or neural function, but we're at a point where we can improve function. And like what one new program that we started is this MRI guided focused ultrasound, where essentially we create a lesion in the brain in the MRI suite using ultrasound waves, um, where instead of deep brain stimulation, we can create a pea-sized lesion in the brain using ultrasonic waves while the patient's awake. Those, at least for me, a deep brain stimulation procedures takes anywhere from 2 to 3 hours. This ultrasound procedures takes about an hour and 15 minutes or so. The patient walks in with a tremor, they walk out without one. It's pretty powerful. It kind of restores patients' ability to take care of themselves. It restores function. A lot of times it restores their dignity. They're able to eat and take care of themselves again. So yeah, I mean, and there's a lot of cool things in neurosurgery that are coming out. I think it's a really exciting time.
And I remember when I was shadowing you, when you were talking about the procedure where they put like a pacemaker like device in the brain to fix the seizures, and I thought that was really cool. And the way that one of the PAs or nurses explained to me was the using the pacemaker to correct like the brain activity, and I thought that was really really cool. And it's like you were talking about, it's crazy how much we've advanced from even 10 years ago to
Mm-hmm.
where we are now.
Hmm.
And this kind of leads me into my next question. Could you walk us through a typical week or a typical day in clinic and kind of some of the cases you see on a regular basis?
Yeah, Grant, I'm not very typical, again, because I do a lot of the other things. But at least for me, so fortunately, yeah, I was off the weekend, so so Monday, is usually my operative day. I did a couple cases, 3 cases. I did one is for a Chiari malformation. Essentially, what that is part of the cerebellum, specifically the tonsils, is a little bit lower than the foramen magnum or at the base of the skull. And the patients can have numbness in the hands and severe headaches and that sort of thing because of the compression of that part of the tonsils that are compressing the brainstem essentially. So we did a Chiari malformation. We removed part of the skull and suture into a graft to a dural graft to make sure that there's more room for the cerebellum. Um, and spinal fluid and so forth. Then after that, I did a posterior cervical fusion and decompression for a gentleman with cervical myelopathy who had a previous anterior fusion by one of my partners a while ago, and he had since moved away. My partner moved away. So this guy had some what we call adjacent level disease. So those levels that were fused previously, they're at risk of the levels above and below are at risk of degeneration. So we ended up operating on that. And then I think I did like sort of I think a washout or something like that. And then I had to, after that, had to make a meeting. And then on Tuesday was mostly clinic. And then I had a meeting. Well, in the morning, I had a meeting at 6:30 and then to 7, and another meeting from 7 to 7:30. It was in clinic at 8 till about 4, and then had another meeting, and then home. And then on Wednesday, another meeting at 6:30, uh, and then was operating. I forgot exactly what I did. I know it was even yesterday. Forgot exactly what I did yesterday, but um, uh, on yes or today, uh, did three cases. One was a was all in the endovascular suite today. That's usually my endovascular days. So we did a carotid stent for patient had a symptomatic carotid artery stenosis, so we stented it. Patient had a radiation in the past and fortunately had some stenosis and had some strokes from that, so we stented it today. And then patient had a stenosis, but also had an aneurysm. So we stent assisted coiled the aneurysm, stented the carotid artery, and then just now did a before joining you did a coiled an unruptured aneurysm. So and then tomorrow clinic. I have a meeting in the morning, then clinic, and then a bunch of meetings in the afternoon. So that's my and then I'm on call this weekend. So that's a my typical week, I guess. Yeah.
And I think that's really cool. I mean, there's no specific thing that you do each day. It's more of a whatever the day kind of
Yeah. Yeah.
says. And I think that's really awesome how it's a little unpredictable. I know some people like very like planned out schedules, but as someone who likes spontaneity or seeing different things and always like kind of being on my toes and challenging like myself, I think that's something that I would find a lot of passion in.
Hmm.
But yeah. And so you work hand in hand with neurology, and I was wondering if you could kind of explain the differences between neurosurgery and neurology outside of the actual performing the procedures.
Yeah. Well, very similar to ortho neurology. We do a lot of neurologists can also do endovascular. So radiology, neurology, neurology, and neurosurgery can do endovascular procedures like the things that I did today. Just need the fellowships, right? But to answer your question, so yeah, I work hand in hand with other things when it comes to the epilepsy. That's it really. Epilepsy is a very much a team based pathology that we have to work with. So we work with them to help kind of determine where the seizures are coming from, and honestly, a lot of majority of the workup comes from neurologists. They're the ones who, if anything, have a tremendous amount of passion in kind of helping me figure out where these seizures are coming from. That way, we can have a discussion how to treat it. Either we can destroy that area by either resecting it or using those lasers to ablate it, or we can use stimulators to essentially inhibit those areas. Um, Another thing is with movement disorder like Parkinson's and tremors. I work with another group of neurologists that help me with that. And that's also in part with each of them is psychiatry too, because we have to make sure things like their depression and making sure that they're not they well depression is under control, that that as the psychiatry portion also make helps us make sure that their social network is supportive enough to have these procedures done, and also to make sure that these patients understand what they're getting themselves into is extremely important as well. um is with the other side of neurology, when it comes to endovascular stuff like stroke work. Again, the neurologists take really the brunt of the calls. So really, I'm not activated until unless there's like a thrombus in one of the arteries that I need to. They think that the patient would benefit for me to do a thrombectomy or to chase. So yeah, it's extremely to have you. It's not always the case, but it's very helpful, and I think it's a really um, it, it, it's much easier to have a successful career, successful program to work well with neurology. Um, and I think these days it's a lot better. I mean, meaning that I think especially me working with a lot of the younger folks, I find that that ego isn't really there. Those kind of egos and those kind of problems that I've seen when I was training, between in a lot of the headbutting between like orthopedics and neurosurgery and neurology and neurosurgery. I don't really experience that. It could be just because, I get along with the folks that I have here. But I don't really see that anymore. So,
Yeah, I think a lot of students, freshmen, sophomore, don't understand how much teamwork there is between different specialties and different physicians, and because at the end of the day, you may not know a certain may not have knowledge in a certain area, but another physician would. So putting two heads together to come up with a problem is really efficient. And finally, to our last question, this is a little bit more of a chill question, and I know being with you in the OR, I get to hear a lot of music. So I was wondering, what's your favorite song to play in the OR?
uh, it depends. I mean, if it's something that I really want to be chill about, I mean, I'm from the 90s, right? So I listened to a lot of Fugees and Outkast and that sort of thing. That's kind of my thing. But if I need something, so it's a head bleed and need to get in and out and that sort of thing, I need that motivation, kind of Beastie Boys and uh and the White Stripes and that sort of thing. Um but yeah, I'm open to, whatever, not anything, but I'm open to a lot of things in the operating room. Usually in the IR suite, I need to kind of something a little bit more chill. So it's usually like gorillas, that sort of thing. And also, a lot of those patients are awake when um when I'm doing these procedures, especially the diagnostic part. So I usually give them the option to listen to things. So it's not uncommon that we are in the South, so it's not uncommon that they want to listen to like Christian or country music, which I have to just it's not they're not all bad, but I gave them the option, so I have to go through it. But also, those kind of you all one thing though I learned early on is that you gotta I try to keep away from I'm a big Wu-Tang fan too, so but at the same time you gotta be a little bit mindful of everyone else's sense of decency and stuff. That was one of the funny things that I kind of got in trouble with was just my music early on was getting written up. Of all the things, I would get written up because I was listening to the music that I was listening to. So, that's one thing that you just gotta keep in mind, So, but yeah, no, that's what I listen to. Yeah, a lot of Fugees, a lot of Outkast, Beastie Boys, White Stripes, a lot of Gorillas in the IR suite. Yeah. Hmm.
Yeah, I know when I was in the OR, I enjoyed the music, so you had
Good,
no
man.
issues covering
Yeah.
me.
Yeah. If that was your main impression of me, I'd say that was a successful rotation.
But Dr. Mangubat, we truly appreciate you being here today and talking to us about neurosurgery and research and honestly just everything. And I appreciate you taking the time. And I know you have a super busy schedule, so we really do appreciate you being here.
No, thanks for giving me the floor and everything. So yeah, I'm always happy to help in any way. Yeah.
Well, with that being said, that is the conclusion of today's webinar. For if you have any questions while watching this recording, feel free to post it on the PhysiLink website, and we will send that to Dr. Mangubat to answer. But thank you guys.